Assalamu alaikum. So I think it's almost 9 o'clock, so we'll start. Thanks a lot for coming. So we have got first session is hematological malignancies, and next is going to be followed up by BMT session as well. So please be seated with us for this whole morning. It's going to be diverse talks from national and international speakers from various key topics, and obviously the cutting edge up-to-date information will be shared. So the chair of our session is Dr. Nadia Sajid. She's a head of department of clinical hematology in Mole Hospital and a consultant clinical hematologist, Dr. Nadia Sajid. Uh, and our co-chair is Dr. Bushra Hassan. She's a consultant clinical hematologist and bone marrow transplant physician from Shaukat Khanum Hospital. So our first speaker is Dr. Tanya Siddiqui. She is not she does not need any introduction because she's a well-known person nationally and internationally for her expertise in CLL and CAR T cell therapy. She is a professor at City of Hope Hospital, Duarte, California. She has got a recorded talk and she's online as well. Over to Dr. Tanya Siddiqui.
Assalamu alaikum. My name is Dr. Tanya Siddiqui from the City of Hope, Orange County in California, USA. I am the medical director of lymphoma and the CAR T cell therapy programs at City of Hope, Orange County, and the director of the CLL program at City of Hope here in California. And I'm here to talk to you about CLL, upfront treatment, and first relapse. In this day and age, targeted therapies have become the mainstay of treatment in CLL, such that really nowadays, at least in the Western world, or at least in the US, I should say, we don't really use chemotherapy anymore in CLL. And you can see from this diagram that there are a lot of molecular targeted therapies to different enzymes and molecules in the body, meaning in the cancer cells, I should say, targeting things like BTK, BCL2, PI3K, CD20 on the surface. And the list keeps growing. We have more and more products that I haven't even shown here in this diagram, BTK degraders, bispecific antibodies and such. CAR T cell therapy, of course, but we're going to focus on the first line therapy and then the first relapse therapy that we preferentially use nowadays. So what are the considerations for selection of first line therapy in CLL nowadays? Really, I feel like we can use pretty much any of our novel targeted therapies in any age group. And the main thing we look for nowadays is the prognostic markers to see whether somebody has deletion 17p, TP53 mutation, unmutated IGHV, very high burden of disease where you need to control things very quickly, meaning advanced stage of disease, when we're trying to pick what kind of treatment to begin with. And we pay attention to patient comorbidities, of course, because if somebody clearly has a lot of cardiac disorders, we want to make sure we don't start with a BTK inhibitor preferentially. And if they have, like, let's say, severe renal impairments, then you may not want to start with venetoclax preferentially. But a lot of times we can still do some of these treatments down the line for these patients if we really need to use our best in class treatments down the line as well. I think the main discussion I really have with patients nowadays when picking frontline therapy is whether they're interested in continuous treatment over a long period of time, much like they take their diabetes or cholesterol medications, to control the disease more gently over years and years of treatment. And those are usually my older patients. And then the other option is, do they prefer fixed duration therapy, where you're done with 1 year or 2 years max of treatment, and then you can take some time off treatment for many years potentially. And sometimes the genetic markers play a role in this decision as well, but a lot of times it's, patient preference. Hey, the younger patients just say, hey, I just want to get finite treatment and then go back to living my life. Some people say, look, I wanna have the security of being on something continually that tells me that my cancer won't come back in any, major fashion quickly. And so this is the main discussion that I have, and so let's talk about continuous treatment options in the frontline setting. BTK inhibitor monotherapy is the main first thing that came about, now, more than 10 years ago, I want to say. And this data from RESONATE-2 trial comparing ibrutinib, which is the first-in-class BTK inhibitor, to chlorambucil single agent therapy, has now been updated year after year, showing excellent results with ongoing progression-free survival and overall survival advantage. And on the right, you can see the initial alliance trial comparing ibrutinib to bendamustine and rituximab. There are other treatments down the line that came E1912 trial in younger patients comparing ibrutinib plus rituximab to FCR, etc. And all these trials have always shown that the ibrutinib containing arm did much better in terms of progression-free survival than the chemoimmunotherapy containing arm, such that last year, this was a very striking statement that came out, a paper that was published by Dr. Paula Villa, that basically said first-line ibrutinib treatment in patients with CLL is associated with overall survival rates similar to those of the age-matched general population. And this is, of course, in the Western world where a bunch of these large initial ibrutinib trials were the data was pulled together from the patients on multiple of these trials, RESONATE-2, etc., where you can see on the top right curve that the patients who got ibrutinib, whether they had good risk genetics or bad risk genetics, all seemed to live their full life expectancy, as compared, to the age-matched general population of the time. Whereas below, in the diagram below in the green, you can see that the patients who got chemoimmunotherapy on any of these trials actually lived less than their age-matched general population comparisons. And so their life expectancy was shorter. And so this is very striking, and it tells us right away that ibrutinib-based therapy or any of the novel treatments actually are really the way to go. And that's why nowadays in the US we do not do chemoimmunotherapy for CLL patients. By and large. So talking about BTK inhibitor therapy then, so what came after ibrutinib was acalabrutinib and then zanubrutinib, and you can see in these trials, these large trials, which were randomized trials, on the left, the ELEVATE-TN trial showed, even after ongoing follow-up, that the acalabrutinib containing arms, either monotherapy or with obinutuzumab, was significantly better in PFS to chlorambucil obinutuzumab, and on the right, Zanu was better than bendamustine and rituximab. So the story continues, it's the same story. What we haven't been able to answer clearly is whether or not we need to add CD20 monoclonal antibody to BTK inhibitor continuous therapy in the frontline setting. There are many trials showing ibrutinib compared to ibrutinib plus rituximab. Both did as well when you compare it to bendamustine rituximab in the alliance trial. In the middle, you can see ibrutinib plus obinutuzumab did remarkably well compared to chlorambucil plus obinutuzumab, and on the right, you can see in the ELEVATE-TN trial that acala plus obin seems to be doing even better than acala alone, but definitely both arms did much better than chlorambucil obinutuzumab, and so it's not entirely clear whether you need the obinutuzumab, but there is data to support that obinutuzumab is better in CLL than rituximab if you do try to use a CD20 monoclonal antibody. And sometimes if I've had patients who have many side effects of BTK inhibitor therapy that are annoying, like joint aches and bruising, bleeding, that kind of thing, where they can continue BTK inhibitor, but they're miserable sort of thing. I do try to consolidate with obinutuzumab and then maybe give them a treatment holiday from the BTK inhibitor. If they have to stop, they might as well stop when they're in a deeper remission so they can stay off of treatment for much longer. And single agent BTK inhibitor doesn't get you that very deep remission for a very long period of time, unfortunately. Even though it works extremely well for disease control, which is the goal, as you can see on the left here, as an advantage for years to come, even in people who have deletion 17p or TP53 mutation. But on the right, you can see the disadvantages that it is continuous therapy, so there'll be some cumulative toxicity like hypertension, infections, etc. And you know, there is a financial toxicity associated with this year after year if you keep taking these very expensive medications. And then rarely we do see more and more resistance emerging years after being on BTK inhibitor therapy, such that BTK mutations can emerge. Although I wouldn't say that is a very common problem, and so we haven't been burdened by that as much currently, thus far, I should say. And what about fixed duration therapy? So in the frontline setting, I'll talk about the CLL14 trial first on the right. Really, this put venetoclax plus obinutuzumab on the map, comparing it to chlorambucil obinutuzumab in patients who had some comorbidities, might have been frailer. Really, the venetoclax obinutuzumab arm after 1 year of fixed duration therapy. So 6 months of obinutuzumab, 1 year of venetoclax, in that gray bar. Everybody stopped treatment on the venetoclax arm, and then chlorambucil obinutuzumab is also fixed duration, of course. And if you follow these patients year after year, the ven-obin patients continue to do extremely well for many years, especially if they have good risk genetics. On the left, the Gaia CLL13 trial compared many different combinations of venetoclax to chemoimmunotherapy. And here you can see clearly, unfortunately the blue line hasn't showed up very well, but where it says ven-obin in the darker blue, the PFS line actually mirrored the IVO gray PFS line just underneath, and that IVO is a triple drug regimen, ibrutinib, venetoclax, and obinutuzumab. So it wasn't clear that you needed to really add the ibrutinib to the ven-obin, at least on this particular trial, but you can see that the ven-rituximab arm PFS was much worse than the ven-obin PFS, and that's why I said previously that we think that obinutuzumab is a much better CD20 monoclonal antibody in CLL. On the CLL14 trial, again, year after year of follow-up has shown that patients who have TP53 mutation on the left or unmutated IGHV on the right, they do a little bit worse in PFS compared to none of these forest markers, which is the topmost PFS line in both of these curves. But I'm encouraged by the fact that even with TP53 mutation, median PFS is in the realm of 4 years or so after treatment finishes, and for unmutated IGHV even longer, 5 plus years or so. So people can still get a long treatment holiday after 1 year of ven-obin, even if they have poorest genetics. And then the second fixed duration option nowadays that is emerging is a combination of venetoclax plus BTK inhibitor therapy plus minus CD20 monoclonal antibodies. And you can see that the GLOW trial put ibrutinib plus venetoclax on the map, such that these are older, frailer patients, and basically this trial led to EMA approval of I+V in Europe, not in the US thus far, unfortunately. And again, as I mentioned previously, the IVO arm of the Gaia CLL study seemed to have the best PFS along with ven-obin. The Sequoia trial is also evaluating a venetoclax plus zanubrutinib combination arm, which seems to look extremely well thus far, although we need longer follow-up. And then on the left, the graph that changes the Captivate fixed duration therapy graph. Basically, that showed in a single arm fashion that venetoclax ibrutinib combination for 15 cycles really can give you a very long progression-free survival for years to come afterwards. And then these are the very deep, undetectable minimal residual disease rates, which were the deepest in the red bars for IVO combination therapy, and then in the turquoise bars for venetoclax or obinutuzumab. So those two combinations lead to the best undetectable minimal residual disease. The depth of remission is very strong with these combinations. The FLAIR trial also showed I plus V to the point of undetectable minimal residual disease, and then double that time that it took to get to UMRD has proven to be, to have a PFS and NOS advantage over FCR in the UK. And pretty deep undetectable minimal residual disease rates as well. And so ongoing follow-up to see how long these patients remain in remission once they come off study, meaning off treatment, it continues to be followed. And the Amplify trial put acalabrutinib plus venetoclax on the map, plus minus obinutuzumab. We weren't able to kind of prove that you need the obinutuzumab here again. With the triple drug regimen, we worry more about infections, and they were seen in this trial as well. But PFS and overall response rates were remarkably better than FCR and BR with A plus D regimen or APO regimen. And so with fixed duration, you have the advantage of getting into a deep remission with higher complete remission rates, higher rates of UMRD, longer PFS with the CD20 combination, but with the 2-pill combination, you have the advantage of just being on 2 pills without having the issue of coming in for infusions. And then they can be pretty expensive because they're 2 pills, and since they're not FDA approved in the US yet, I don't do a lot of the 2-pill combination unless it's on a clinical trial. And so now we're starting trials that are combining zanubrutinib plus sonrotoclax, which both come from the same company. And so that may actually show us ongoing benefit of the 2-pill regimen. And so both continuous and fixed duration treatments have their own pros and cons, and that's why it has to be a combination, it has to be a conversation with patients. I will point out that in the frontline setting, there are some trials that are still ongoing or have completed accrual that we don't have results on, which will tell us categorically, directly, in direct comparison, prospectively, whether the 2-pill regimen is better than Ven-Obin or not, because Ven-Obin has set a very high bar. In my opinion, it's my favorite regimen personally myself for patients. And it's the shortest combination therapy thus far that we have freely available in the US. With these AV and sonrotoclax type regimens that are being evaluated currently, that are also 1-year regimens, but may or may not have as good progression-free survival as we've seen with Ven-Obin, and that remains to be seen in these direct comparison trials. So I'm excited to learn of this data when it gets analyzed in the coming years. Talking about sequencing at first relapse. So my practice is that if somebody starts with fixed duration, venetoclax, COVID type combination therapy, I'm presuming it's going to be years later that they relapse, and I try to do a different mechanism of action at that time, namely BTK inhibitor therapy, usually in combination, but not always. And it depends on what the patient condition is at the time, et cetera, as well, but and what the genetics are of the CLL, but there is data to support that you can use fixed duration venetoclax plus obinutuzumab or rituximab again, and that's mainly coming from the Murano trial and other data. And then vice versa, if you start with a BTKI regimen and you progress on that, you can certainly change to a different BTKI. Nowadays, we try to go to non-covalent BTKI if the patient was on continuous covalent BTKI and then progressed. But certainly switching to venetoclax, rituximab, or obin combination is a very, very good option as well. So I try to switch tracks if I can. The progression-free survival is shown in these first relapse, or I guess relapse refractory patients. A lot of them may have been first relapse, but not all. And these data are older trials where, again, you can see that Van does very well compared to chemo, ibrutinib or acala do very well compared to chemo as well. But in this day and age, a lot of people will have had frontline novel therapy, never had chemo, and the second line will also be a novel therapy. And so there is prospective data pending to see how well patients do with the second line novel drug therapy as well. But in reality, by experience, what we know is that the second line novel therapy works extremely well. The same drugs can work again. And like I said, I like to switch class, so try a different BTK inhibitor if you've already had one, or switch to venetoclax if you've already had BTK in the past. In the relapse setting, acala and ibrutinib were tested head to head and showed no difference in PFS, but acala was better tolerated from the cardiac standpoint. And in the alpine setting, zanubrutinib and ibrutinib were compared head to head. Different group of patients, not all high risk, unlike the acala and ibrutinib trial. But Zan came out showing a progression-free survival advantage over ibrutinib in this setting, and again, the toxicity profile again showed that cardiac risk was lower. So zanubrutinib is one of our favorite novel BTK inhibitor therapies to start with. And then here for venetoclax based therapy, you can see the Moran trial showed venetoclax plus rituximab doing extremely well. And on the right, there's the revenge trial that's ongoing, which is retreating patients with ven-oben after the CLL14 type regimen, fixed duration regimen, in a couple of different fashions, 1 year again versus 2 years of therapy, and for various reasons, and we will await to see what the results of this show, although I anticipate patients will do extremely well with retreatment with ven-oben again. So in conclusion, there's been an explosion of novel therapies for CLL in recent years, and the list keeps growing. The list keeps growing, and we hope to get better and better at what we do with the combinations that are coming, such that maybe we can function. We are already functionally curing patients, because patients can live their entire lives with novel therapies, or taking breaks and restarting in the future, etc., as needed. But we hope to one day completely eradicate and cure CLL in a way that that patients don't have to worry about it coming back again at all. And with that, I thank you for your attention.
Thank you, Dr. Tanya. So have you got Dr. Tanya online? So if she is available, we can do Q&A right now for her. Otherwise, we can do Q&A for all these sessions at the end. Dr. Tanya?
I'm here. Assalamu alaikum.
Hello. Can you hear us?
Yes, I can hear you.
I think you're mute.
Oh, I can hear you. Can you hear me?
Yeah. So,
Oh.
so thanks a lot for it's probably a night time for you. So thanks a lot for
Yes.
that's very kind. So we'll start the question on session from a question from myself. Again, a very concise talk for upfront treatment of CLL, and obviously in a lab setting as well. So fixed duration versus long-term treatment. What do you think? Where we are heading in the overall in general, in the context of CLL?
That's what I had tried to sort of explain. I think our general sense is that we would like to have fixed duration therapy, give people a break. There's data emerging that maybe that way you can prevent clonal evolution of future mutations and things like that, that can make CLL worse over time by just being on one treatment for years and years and years. And patients like that. I think patients like to come off of anti-cancer therapy, take a break. The majority of patients, I should say. For some patients, it's a security blanket, but majority of patients want to stop treatment and kind of just live a normal life with normal counts, if at all possible. So I prefer the fixed duration approach, and I think that's why a lot of these combinations are being tested now to see, can we just do 1 year, 1.5, 2 years of treatment and give people a break after that.
Okay, thank you. So we got one question from the hall.
Question from my end. Thanks for the excellent talk. What do I comprehend from your talk? Giving treatment for lifelong till the progression of disease is not possible in our setup. So the holiday time period should be specified in months. What's your clinical experience regarding that?
So at least in the US, we are lucky enough to be able to give all these treatments. And I understand that these treatments are not all available or cannot be afforded in Pakistan thus far, although we're all trying to find ways to have Pakistan access more and more of these treatments. Even on my end, I keep trying to talk to companies, etc. But if you are able to get patients in a deep remission, let's say Ven Obin, you have the ability to do a 1 year treatment course with Ven Obin. Majority of patients will be in a very deep remission, and if they have good risk genetics like DELS 13q, mutated IGHV, then they can actually go. Now we're now 7, 8 years and counting such patients who don't, not needing treatments again. If somebody has porous genetics, like let's say TP53 mutation or DEL17P unmutated IGHV, if those people get 1 year of an Obin treatment and get in a deep remission, they may relapse by around year 4 or 5, but even that is a very good and long treatment-free period where you can just watch and wait again until they need treatment again and maybe use the same regimen again in the future.
Thanks.
Thank you very much, Tanya, for excellent talk as ever. I just have two small questions. Given irrespective of financial toxicity, if you have to compare between two, Obin venetoclax or BTKI inhibitor and venetoclax, can BTKI and venetoclax be fixed? One question. And what do you compare? How do you compare both? Second question. And you have not thrown light upon the people like us who use BTKI monotherapy with just one tablet going on very nicely for years. So what's your opinion about that? Thank you.
So question one, I think you asked about Ven plus BTKI, and that clearly is being studied now in a fixed duration manner. So acalabrutinib plus venetoclax has already been shown on the Amplify regimen to be a 1 year, 15 cycle fixed duration regimen. I plus V, ibrutinib venetoclax, has been shown to be a 1.5 year regimen in one trial, 1 year regimen in another trial. Getting very deep remissions again, but the two pills together are expensive. I forgot your second question. But the third question about the one pill of BTK inhibitor therapy, yes, it can work very well for a long period of time. We know from the very initial phase 1 studies that you need a certain amount of BTK inhibition or inhibitor present to saturate and occupy and suppress the BTK binding sites on the enzymes, on all the enzymes. And it was sort of determined that one pill may not be enough, but 2 or 3 pills or 4 pills are actually very good to do that. So in my own practice, I try never to go down to one pill. I try to stick with 2 pills at the minimum if I can. But if you're hard pressed for doing one pill versus no treatment, it's a good treatment, right? It still works. The question is, will it work a little bit less in years compared to 2, 3, 4 pills that can work maybe much longer? So we don't quite know the answer to that. And I know that there are some studies ongoing now, at least in the US, where they are trying to see whether maintenance with lower dosage will actually lead to long-term control as well. And that data will come out too. So stay tuned. But I think it's a great question, because if you don't need all those extra pills, then you can make those pills last longer by doing lower dosage. And Dr. Osman, you may have to remind me about the second question. I've forgotten. Beach wala kaun sa question tha?
So she's answered it.
Did I answer it?
Yeah, so I think the question was about vinotuzumab and venetoclax comparison to the BTK inhibitor and some anti-CD20. What's your preference?
Yes. So BTK plus anti-CD20 has not sort of been a fixed duration regimen yet. I personally do it much like you guys do the one pill of BTKI, because that's the clinical judgment. It has to be done, and that's the only way it can be done. In my practice, I do fixed duration BTKI if somebody is having, I start them on, let's say, Brukinza, or meaning zanubrutinib or ibrutinib or whatever, and they have these annoying arthralgias or rashes or diarrhea, and it's not high grade, it's not grade 3 or very severe toxicity that you have to stop the medicine, but it's low grade and annoying. So they can't envision living their entire lives with like that much, diarrhea every day or that much arthralgias every day, because they're fairly miserable. So then what I do is I add obinutuzumab once a month for 6 months just to get them in a deeper remission, and then I stop the BTK inhibitor as well. And then they can go maybe 2-3 years without relapsing, whereas if I had stopped just the BTKI without adding obinutuzumab, they would have maybe relapsed in less than 1 year. 9 months or so is my experience. So that's just a clinical judgment thing. There's no good data to support that, but it won't get you in as deep a remission as venetoclax plus obinutuzumab.
Thank you. So we've got one last question from Dr. Saeed Waqasim Bukhari.
Thank you, Dr. Zania. Zania, that was an excellent talk. I've got a couple of short questions. The first one is, so we also obviously use Venubino. It's quite a favorite fast here as well for patients who can afford it. But I quite often get this question after completion of 1 year and we do their marrows and scans. So if they do not have an MRD negativity, they still have got some disease. They ask us what next. So if they have had a good response, but they're still, they've still got disease and they're MRD positive, what do you tell them? Do we need to treat them further, or we just stop? And secondly, is there still any role in any specific subtype of CLL of FCR?
Not in the US. For the second question, we don't do FCR anymore. In Europe, every single country may not have, and other parts of the world for that matter, they may not have all the novel agents that we are blessed with, so to speak, in the US. And so there are other countries who still use chemoimmunotherapy, and some of the trials that are comparing some novel combinations are still comparing them against chemoimmunotherapy, but mostly outside the US. So personally, we don't do chemoimmunotherapy anymore in the US. So I don't have the experience to tell you that would any subclass of patients be eligible for it. There was a time people believed that the good risk genetics like mutated IGHV and del13Q and younger, fitter patients could potentially benefit from FCR. But I think if you look at the E1912 trial some years ago, it's a phase 3 randomized frontline trial in this exact patient population, good risk, younger, etc. And pretty much everybody did better with ibrutinib and rituximab compared to FCR. So it's a little bit harder to sell FCR now with all the toxicities that it can potentially have. I think in answer to your other question about Ven-Obin, that's a really realistic question. The way that the CLL14 trial was done was everybody stopped after 1 year, didn't matter what their MRD status was. Now that we have the ability to check for MRD, I usually do try to check for MRD when I'm getting ready to stop venetoclax after 1 year. But it's more to kind of just counsel the patient and know myself that, okay, maybe you might not be the one who goes 7-8 years without relapsing. Maybe in 4 years, 5 years, you might need treatment again. But I still don't not stop. The only situation where I hesitate and I might think about continuing venetoclax would be, let's say they have TP53 mutation and are still MRD positive, and then I kind of have a discussion like, okay, maybe you might relapse even sooner, like 2-3 years instead of even 5 years. But even then, some patients say, no, it's okay, we'll just stop, take a little break, and then we can always go back. When we start relapsing, we might not wait till the white count is 100, but we might, restart sooner. So I would still stop after 1 year of Ven-Obin in most patients.
Thank you, Dr. Tanya. Much appreciated. So thank you, Dr. Tanya. So thanks a lot for your excellent talk and even more excellent Q&A session. It was much appreciated.
Thank you for inviting me. Hopefully I can be there in person another time.
Hopefully, yeah, hopefully.
Inshallah.
Assalamu alaikum. We are incredibly honored to have second speaker from Armed Forces Bone Marrow Transplant Center, Brigadier Mehreen Ali Khan, to enlighten us with the acute myeloid leukemia treatment alternatives.
बिस्मिल्लाहिर्रहमानिर्रहीम रब्बी शरह ली सदरी ऐ अल्लाह ताला मेरा सीना खोल दे वयस्सिर ली अमरी और मेरा काम आसान कर दे वाहलुल उक़दतम मिन लिसानी मेरी ज़बान की गिरा खोल दे यफ़क़हू क़ौली ताकि सब लोग मेरी बात समझ सकें. So respected teachers, Sir Nisar is sitting here, Sir Tariq Ghafoor is sitting here, dear colleagues and brilliant, vibrant students, Assalamu alaikum, a very good morning. I am Mehreen Ali Khan from Armed Forces Bone Marrow Transplant Center, a hematologist and a transplant physician. And my task today is to discuss the management of AML with focusing upon the alternates of very long cherished D3A7, that is dark chemotherapy, with significant morbidity and mortality, which we come across every day. So I would like to start from another verse, very pertinent from Holy Quran, ayat number 11 of Surah Ra'd. Inna Allaha la yughayyiru ma biqawmin hatta yughayyiru ma bi anfusihim. Indeed, Allah will not change the condition of people until they change what is in themselves. And it has been beautifully translated by my inspiration, Allama Iqbal Rahmatullah Alayhi. खुदा ने आज तक उस कौम की हालत नहीं बदली, ना हो जिसको ख्याल आप अपनी हालत के बदलने का. So I'll apply it to myself. It's we, the hematologist, medical oncologist, pediatric oncologist, who are responsible for provision of all the facilities for the better diagnosis of AML, for the better risk stratification of AML, so that we reach to better management plans. I don't have anything to disclose. So as all of you already know, AML is genetically heterogeneous, very aggressive cancer of myeloid lineage, characterized by rapid proliferation and block in differentiation, which results in accumulation of all these blasts in the bone marrow, and then these blasts spill over in the blood. So what I would like to stress upon for the juniors is, do look at the peripheral blood film. After proper history, clinical examination, first and foremost, investigation for AML patient is peripheral blood film. 90% of the cases you can come to a conclusive diagnosis after peripheral blood film examination. And then comes bone marrow, immunophenotyping, molecular genetics, and of course, cytogenetics. So few basic facts about AML. If you look at this bar graph, you would come to know, I think the pointer is not working. Okay. So if you look at the bar graph, you'll come to know that the most of the patients are lying after 65 years of age. But this is Cancer Research UK. So where is our data? Where is our registry? So I would like to stress upon the second point after peripheral blood film examination, that we should have our own AML registry, we should have our own distribution data, because all of us sitting here see the patients in the clinics 1 or 2 decades earlier than the Western data. Always. It's 1 or 2 decades earlier. So in 2012 to 2018, US data, that is statistics, epidemiology, and end result, seercancer.gov, 30.5% 5 years overall survival in AML. Estimated cancer in 2022 were 20,000, and 11,000 out of them died, and 1.9% of all cancers were AML. So in the same SER data, you see once again, that is the median age at diagnosis is 68 years. So we see in the clinics much younger patients. We should have our own data, our own AML registry, and our own devised ways of treating AML. So the most important thing, as Dr. Tanya was saying, everything, the paradigm has shifted to the better diagnosis. So if you see at the genetic mutations in AML, there are many signaling genes, FLT3-ITD, FLT3-TKD. There are myeloid transcription factors like RUNX1, RUNX1T1, which was previously called AML1-ETO, nucleoplasmin, NPM1, spliceosome gene mutation, chromatin modification genes, DNA methylation gene, DNMT3A, and tumor suppressor gene, the notorious TP53. So if you look at the percentage of different mutations, FLT3 was at the maximum, that is 37%, but this was 2012 data published in NEJM. We need to publish our own data combining all the centers together from the forum of PBMT or PSH. Then NPM1, DNMT3A, and the list goes on. IDH1, 2 are available. The inhibitors are available. So if we don't know that IDH1 mutation is there, how would we prescribe ivosidenib? Or how would we prescribe enasidenib? So, and in the end comes TP53. So in 2024, European Leukemia Network published genetic risk classification for AML, which is very pertinent. Favorable risk, as all of us already know, mutated NPM1, mutated IDH1, IDH2, adverse risk mutated TP53, and other cytogenetic abnormalities come in intermediate risk. And they have the impact upon median overall survival. So you see from 23 months to 39 months median OS in the favorable risk, 39 months is a lot. And if you compare it with the adverse risk group, it is just 5 to 8 months. So meaning by that confirmed laboratory diagnosis rightly done leads to better management plan. This is a very, very interesting slide showing us the landscape of how these therapies were devised over the last almost 50 years. In 1973, when I was 1 year old, D3A7 came in. And for the next 20 years, D3A7 continued and continued without addition of anything else. However, in 1977, first bone marrow transplant for AML was done. And then came gemtuzumab ozogamicin, that is GO, anti-CD33 or Mylotarg, with lots of toxicity. In 2002, idarubicin came in. In 2010, gemtuzumab ozogamicin was withdrawn from the market, as all of us already know, due to its toxicity, not proven superiority. Then came midostaurin, FLT3 inhibitors. So if you know that FLT3 is there, you'll plan FLT3 inhibitors. If you don't know FLT3 is there, and if your lab reports are not reliable, how would you go for FLT3 inhibitors? Gemtuzumab ozogamicin came back in the market with reduced doses, and CPX351, that is liposomal daunorubicin and Ara-C with lesser complication, and enasidenib, that is IDH2 inhibitor. Then came ivosidenib, IDH1 inhibitor, gilteritinib, that is FLT3 inhibitor, second generation, venetoclax, BCL2 inhibitor, my very favorite drug because it is oral, easily available, and we have devised that we give lesser dose of venetoclax with voriconazole, just 100 mg with voriconazole BD makes more level of venetoclax, despite the fact that no chemical pathologist has ever tested the drug levels of venetoclax in the serum. And then the revolutionary drug, that is hypomethylating agent, azacitidine and decitabine, giving the opportunity of 60 years old and 70 years old to live and have treatments. 2022, olutasidenib, that is IDH1 inhibitor, quizartinib, FLT3 inhibitor with lots of cardiac toxicity, and revumenib, menin inhibitors. And then list goes on till BiTE, bispecific T-cell engagers, and CAR T-cells. So this is the list: BCL2 inhibitors, hypomethylating agent, FLT3 inhibitors, IDH1 inhibitor, IDH2 inhibitor, menin inhibitor, and other approved agents. When I was given this topic of alternates to dark chemotherapy, practically, what alternate do we have? In Pakistan, we just have one alternate, that is hypomethylating agent with venetoclax. No other alternate of D3A7 is available other than the targeted agent, and targeted agent have to be added with chemotherapy. They can't take care of the AML alone. So you add FLT3 inhibitor with D3A7. So practically we have just one alternate, that is hypomethylating agent, and flag-ida or flag-dono are the salvages. They are not the alternates. So this is the conventional approach in our clinic. When we see the patients, if the patient are less than 60 years of age, they have good performance status, all of us advise D3A7. If the patient is more than 60 years of age, there is no comorbid and patient has good performance status, no therapy-related AML, we might start with D3A7 or we might alter this to D2A5. And if there are unfavorable risk factors or therapy-related AML, we start hypomethylating agent and venetoclax. In our clinical practice at Armed Forces Bone Marrow Transplant Center, we give azacitidine and venetoclax to the patients who are more than 65 years of age. However, to the patients less than 60 years of age, if we have to decide about hypomethylating agent, we decide decitabine, because decitabine is more myelosuppressive. The younger patient, they tolerate it, but the older patients don't get the benefit from decitabine due to longer neutropenic phase, and they have to get hospital admissions, pneumonias, and all that. So if the patient is more than 60 years of age and you can't give any aggressive chemotherapy, so what do you have in your hand? You just have hypomethylating agent and BCL2 inhibitors, that is venetoclax. So this data was older one. It was in Clinical Journal of Oncology in 2015, that is 10 years ago. New cases were increasing, deaths were almost the same. In older patients, 5-year survival was as low as 10 to 15%. It was not cost effective for many of the families in Pakistan. So this is the list of alternates of DAR chemotherapy, CPX351, that is liposomal, DONO, and RSE, hypomethylating agent, smaller molecules, BCL2 inhibitors, FLT3 inhibitors, IDH1/2 inhibitors, MDM2 inhibitors, which are not available here in Pakistan, XPO1 inhibitors, and the very interesting one, BiTEs, bispecific T-cell engager, CAR T-cell therapy, and immune checkpoint inhibitors. We have used immune checkpoint inhibitors in lymphomas, but we have not tried it in AML. So if you compare CPX351 versus DAR chemotherapy, the study shows 153 and 156 patients of both the categories. And when you compare the survivals, yes, CR rates are better in CPX351, that is 37%, as compared to DAR, that is 25%. And median overall survival in months is also significantly different. Then comes hypomethylating agent and venetoclax, which is my favorite. So we give D3A7 first, patient is not in remission, and if the patient has good performance status, we directly go to flag-ida or flag-dono. If the patient is unable to tolerate flag-ida and flag-dono, we go to directly hypomethylating agent and venetoclax. And believe you me, I have younger patient examples who are now post-transplant, who have gone into remission, who were previously not in remission after flag-ida as well. We have a young colonel, he has been promoted to the rank of colonel after transplant. He was given. So there are many examples. So this is not true that if the patient has not responded to flag-ida or flag-dono, hypomethylating agent and venetoclax would not be of any use. So you can give low-dose RSE with venetoclax as well. There are very few patients who are on low-dose RSE, and sometimes low-dose RSE is given at home with venetoclax oral. So it's a treat for the patient more than 65 years of age, having low-dose RSE in the fridge, giving it subcutaneously and having venetoclax. And in this study, the overall response rate was 75% in these 20 patients, and with estimated 12 months overall survival of 74 months, 74%. That is quite a lot. In hypomethylating agent, we have 3 more, that is gudocitinib, and other novel agents can also be combined with azacitidine, that is HIDEC. These are the histone deacetylase inhibitors. I have never personally used histone deacetylase inhibitors, that is presinostat. And then comes FLT3. FLT3 is a protein which is guided by a gene having 3 domains: extracellular domains, which is immunoglobulin loop-like, transmembrane domain, And then comes the intracellular domain with juxtamembrane domain, ITD, that is internal tandem duplication, which is present in 25% of the cases. Do we get the reports with 25% of the cases of AML with FLT3? No. So we should work upon our diagnostic much more. So TKD mutation, tyrosine kinase domain mutation is found in 5 to 10% of the cases. You have to know whether it is ITD or TKD because the inhibitors are different. So in first generation, that is sorafenib, which is easily available, not much expensive. First generation takes care of both ITD and TKD mutation of FLT3. However, FLT3 type 2, that is quizartinib, gilteritinib, and all the second generation take care of only FLT3 ITD, not the TKD mutation. And then we have a long list of side effects of these drugs, especially the quizartinib, which has cardiac side effects. Then we have 3 trials comparing all these 3 FLT3 inhibitors, midostaurin versus placebo in FLT3 mutant newly diagnosed AML. If you start induction and consolidation and 12 cycles of maintenance with midostaurin, which is unbelievable in Pakistan. The price of midostaurin, the difficulties of import of midostaurin, nobody can have 12 cycles. However, when it was compared with placebo group, yes, definitely median overall survival was better in midostaurin and obviously just 25 months in placebo. So 74 months and 25 months. It's hell of a difference for an old AML and younger AML as well. So in quantum first trial, quizartinib and chemotherapy in newly diagnosed FLT3 ITD AML were compared with placebo and the similar results. Quizartinib had median overall survival 31 months and placebo had just 15 months. So this is clear. So if you have these mutations detected and then you give the targeted agent with in mind a proper plan of treating AML, then comes these results. And another trial of Admiral, that is gilteritinib, we have at Armed Forces Bone Marrow Transplant Center given gilteritinib to just one patient. She was the daughter of grade 20 officer, having lots of resources, having the resources to get it imported. We transplanted this patient. She relapsed. It was haplotransplant AML with poor cytogenetics. She went to Saudi, had second haplotransplant. We gave prophylactic TLI for this patient, but even then we couldn't rescue. So AML is a very bad disease when it comes to refractoriness. And these are the adverse events, as I was talking about, quizartinib having cardiac side effects, dose-dependent QTC prolongation. So whenever you have few drugs who have been mentioned to have cardiac side effects, QTC prolongation, like you give ATO in AML M3, you have to have your ECG done, QTC calculation before giving the patient these drugs. And then give IDH inhibitors, IDH1, IDH2. These mutations are present in 8 to 15% of the patients with AML. IDH proteins are essential to curb cycle. It catalyzes the decarboxylation of isocitrate to alpha-ketoglutarate in cytoplasm, that is IDH1, and mitochondria, that is IDH2. Our 6 patients are on ivosidenib and enasidenib after detection of IDH1 inhibitor, but where the NGS was done, it was done abroad. So patients who can afford to send their sample to Celgene abroad for NGS panel, detect IDH1, 2, then you can advise IDH1 and 2 inhibitor despite being affordable. Patients do not have the baseline molecular mutations. And most of the times clinicians don't even advise that because they think that whenever we advise, it would not be done. However, few patients can afford to send their samples. And these are the trials of ivosidenib in untreated IDH1 mutated AML response. This is response trial, clearly showing better CR with ivosidenib. Azacitidine can also be combined with ivosidenib. So what we have in hand, we have hypomethylating agent to be combined with targeted agent for those patients who cannot tolerate aggressive T3A7. That is all. So as Tanya was saying, that they have gone away from chemotherapy for CLL and they have come to just immunotherapy. We can't do it in AML. We can't go away from D3A7. It is here, it would be used. However, whoever tolerates it gets a deeper remission, goes to transplant, remains disease-free for a longer period of time. And now we have thought of thinking venetoclax post-transplant maintenance as well. We have not started it yet because it is not FDA approved. But in few patients pre-transplant, if they complete 6 cycles of azacitidine venetoclax, they can't go to transplant. We give them venetoclax maintenance, 15 days on, 15 days off, 1 pill of 100 milligram with 2 pills of voriconazole per day, 15 days a month. My few patients are for 3 to 4 years on venetoclax maintenance. It's not FDA approved, it is just case reports. And Agile trial also shows better EFS and OS in intention to treat population with ivosidenib. This is very interesting. Look at it. The data, which has been published by Professor Kadia, who is working in MD Anderson Cancer Center, cladribine, low-dose Ara-C, and venetoclax in newly diagnosed elderly unfit AML patients, but we can also use them in refractory relapse AML if you have tried everything. In last Grand Ward round, Professor Tariq Ghafoor has advised this for one of my patients. He is a pensioner. He has been given D3A7 and 4-IDAC, relapse within 7 months, that is early relapse, came to us. We gave Flagdono, not in remission. We started him on hypomethylating agent with venetoclax. The blast percentage reduced from 30% to 10% to 7%. And in the last AZA-VEN, that is third AZA-VEN, blast was 6%. He has fully matched donor. We are planning cladribine, low-dose Ara-C, and venetoclax, seeing its data. So what do? They combine cladribine, low-dose Ara-C, and venetoclax 2 cycles, followed by AZA-VEN 2 cycles. And 18 cycles go on. 2 cladribine, low-dose Ara-C, and venetoclax, and 5 azacitidine and venetoclax. So you alternate till 18 cycles. So this is the regimen. And look at the results. They have taken total 123 patients, and overall response rate was 85%, with MRD negative in 78%. It is impressive, and with very less toxicity. And just 5 patients died out of 123, that is just 4% before 8 weeks. And median number of cycles after which the response comes in is just 1 to 4 cycles. So if somebody has fully matched donor and that patient attains response, you can take that patient to transplant, And then these are MDM2 inhibitors, which obviously we have taken from the literature. We have not used them. MDM2 is a negative regulator of TP53 that is overexpressed in hematological malignancies. It is not that uncommon as we think. TP53 is found in many AML. And then menin inhibitors, that is revumenib, ziftomenib, and they have their own trials. This is a very interesting diagram showing that pathogenesis of KMT2A rearrangement and NPM1 mutant acute leukemias and menin inhibitors. The MLL combines to give the proto-oncogene effect, and the gene continues producing the blast cells. So if the menin inhibitor are given, they block menin here, and the whole proliferation stops. So the menin inhibitor are really of use if we get them in Pakistan. And these are few trials. I will directly come to the topic of, I'm fascinated about BITE, that is bispecific T-cell engager. I have to take care of the time. BITE and CAR T cells, what mechanism they do it on one arm, they attach to the CD3 of T cells, and the second arm attached to one of the AML antigen 123, CD33, and these immunogenic T cell kill those blasts. And the difference between CAR T is that CAR T cells are taken either autologous from the patient, genetically engineered with the viral vector and reinfused, or they are allogenic, that is allogenic CAR. So we have checkpoint inhibitors as well, but we have not used them in AML. I would quickly go through our data, that is real-world outcomes of hypomethylating agent and venetoclax. My favorite in Pakistan, in our center, we have treated 96 patients with hypomethylating agent and venetoclax, 54 AML and 42 MDS patients, and these were the result. Overall survival was 77.4%, disease-free survival 52.8%, overall response rate was 50%, and many of the patients, more than half, underwent febrile neutropenia, but there was no treatment-related mortality. So it's a big data under publication. Soon it would be published. Another data of 485 patients of all AML in the last 20 years. It's a raw data. I will again say it's a raw data. We have to clean it. But just to show, because it was an opportunity, 61% male, 38% females. Obviously, we see 19 to 60 years of age, 66%. So it clearly shows that our age distribution is different. We had just 23% patient after 60 years of age. Risk stratification was done. It was not available for 42%. 22% adverse risk, 6.8% favorable risk, and 27% intermediate risk. So a big chunk, we don't have the risk stratification. Induction chemotherapy was given D3A7, HMA1 not available, ATO-ETRA because it was AML M3 as well, ADE when we combine RSC with daunorubicin and etoposide, HIDEC, and low-dose RSC and FLAG treatment. Initially, we gave FLAG treatment to very few patients, that is just 0.4% in the first induction. Induction response rate, you can see CR1 was a big chunk, that is 56% if they can go to transplant afterwards, and 30% did not respond, and then 9.4% CRI, that is complete recovery of counts. And consolidation chemotherapy results, the 58% had a response, and then we take them to transplant if they are poor risk. We wait. If they are intermediate risk, we give more consolidation. And if they have fully matched, intermediate risk are taken to the transplant. If they have haplomatched donor, so it's patient's choice. Mostly patients don't want to go for transplant or don't have finances for transplant. And I will again stress upon the fact that when we say that it is intermediate risk, it might not be intermediate risk because we don't have the facility to detect IDH1, 2, and many more mutations. So I would end with it. And this is interesting that in 485 patients, 378 were non-transplant, 107 were taken to transplant, 9 auto, 17 haplo, and 81 allotransplant. Directly to the last slide, if you see the overall survival, interestingly, it was the same with non-transplant, with allotransplant, with auto-transplant. Just haplo showed 64%. Rest of the patients were around 53%. So thank you all for your patient listening. I would like to thank my colleagues, Dr. Hamad Javed and Dr. Ahmad Akram, who helped me with the slides. And the conclusion is that HMA1 is feasible and alternate of DA, targeted agents to be added if detected timely. We should develop local guidelines, local data, early hematopoietic stem cell transplant whenever feasible, and venetoclax maintenance is an alternative. I thank you all, and sorry for overshooting the time.
Thank you very much, Dr. Marine. That was very concise. We'll take questions in the end, but you very nicely explained the only challenge to the time-tested DA is addition of more agents to DA, and only the alternatives only when it's less feasible or an older group. But we'll take questions. We'll discuss about it in the end. Our next talk is from Professor Jasmine Zan. It's a virtual talk. Professor Jasmine is a consultant hematologist oncologist. From Memorial.
The broadly classified here as the initial site of presentation, so they would be
We'll introduce her a little bit first. So Professor Jasmine is a consultant hematologist oncologist in Memorial Sloan Kettering, New York. She's expert in T-cell disorders. She will be giving a talk on evolving management in T-cell lymphomas. So we will start the talk now.
Sorry, sir, it's getting sticky.
Assalamu alaikum. My name is Jasmine Zain. I currently work at the Memorial Sloan Kettering Cancer Center as an attending physician in the lymphoma division. I'm here to talk about the evolving management of T-cell lymphomas in 2025. There are many clinical and biologic variants of T-cell lymphomas. They're broadly classified here as the initial site of presentation. So there could be the leukemic variants that include HTLV1 associated ATLL, or T-cell PLL, or T-cell large granular lymphocytic leukemia. The nodal variants that the most common include anaplastic large cell lymphoma, both positive and negative, and the follicular helper T cell lymphomas, including the angioimmunoblastic cell type, as well as the follicular type not otherwise specified. And lastly, purple T cell lymphoma not otherwise specified cannot be placed in either one of those categories. The external presentations include NK T cell lymphoma, nasal and extranasal type, the entropathy-associated T cell lymphomas, the hepatosplenic T cell lymphomas, subcutaneous folliculitis like T cell lymphoma, and various other subtypes. And then there's the primary cutaneous presentation of mycosis fungoides, sensory syndromes, and many other types of cutaneous T cell lymphomas. First, I'm going to talk about upfront therapy for patients with systemic T cell and NK T cell lymphomas. So for most subtypes, CHOP remains the backbone. CHOAP is used for young fit patients. The addition of etoposide has been shown to improve survival only in positive ALCL. Again, this was before the BV or before the use of rituximab vedotin. But in the US, and including our centers, we continue to use CHOAP for young fit patients, especially if you're considering an autologous transplant as consolidation. For NK T cell lymphomas, limited stage disease, chemo plus radiation is a recommended approach. The chemo regimen should be non-CHOP containing because of the MDR, and the recommendation is to use the asparaginase with GemOx. This latter regimen, the PGemOx, is very effective, can be given as an outpatient. Recently, the use of checkpoint inhibitors is being evaluated in the upfront setting based on data that shows that checkpoint inhibitors in the relapse setting are very effective for NK T cell lymphomas with response rates that are closer to 90 and 100%. There are some rare subtypes of T cell lymphomas, including hepatosplenic, gamma delta, SPTCL, TLGL, and TPLL, where there's really no clear standard or established regimens. It's unclear how to treat these patients. They're usually given some kind of an induction regimen, and the goal is to take them to an allogeneic stem cell transplant as quickly as possible. On the right side, I'm showing the NCCN guidelines, the current NCCN guidelines for upfront treatment of T cell lymphomas, and as you can see, for ALCL, the preferred regimen is a brentuximab vedotin containing regimen, brentuximab vedotin plus CHP. I'll show you the data to support that as a category 1 recommendation based on a randomized clinical trial. For other subtypes, clinical trials are preferred, but there are some regimens that are recommended. But at the bottom, in a very small box, you can see it says first line, consider a consolidation with an autologous stem cell transplant. So I'm not going to talk a lot about this, but the recommendation is that first, at least for nodal lymphomas, including ALCL, PTCL-NOS, and all the T follicular helper subtypes, the patient achieves a CR with the initial induction, and they're otherwise fit and healthy, they should be offered an autologous stem cell transplant for consolidation. Again, this is only for consolidation. They don't achieve a CR, then then perhaps this approach would not be the most effective. This is not to say that new approaches are not being tried. This is the current randomized phase 2 study that is being conducted in Alliance, the Alliance group in the US. It is a 1-to-1-to-1 randomization of different combinations with CHOP or CHOEP. In younger patients. So the arm A consists of PI3 kinase inhibitor duvelisib. Arm B consists of 5-azacitidine, which is the oral formulation of 5-azacitidine plus CHOP or CHOEP, and then the third arm is this CHOP or CHOEP. The study is ongoing and does include looking at MRD evaluation as well. And we'll see what the readout is going to turn out to be. Here, I just wanted to mention some of the novel approaches that are being evaluated for the upfront treatment of NK T cell lymphomas. And there are many studies out there, but I just chose the 2 abstracts that were presented at the recent ICML meetings in Lugano 2025. On the left side is a study that combines a checkpoint inhibitor with pegasparaginase and a GFR inhibitor. Along with radiation as induction regimen. Again, this is a limited stage disease. And on the right side, the study was designed for elderly frail patients and is looking at pembrolizumab in combination with involving radiation. This is a study that goes on for about 2 years. And we'll see what the outcome is going to be. So now moving on to relapse disease. Relapse disease remains a major challenge in treating patients with T-cell lymphomas, since most patients will relapse after induction regimen, in spite of, sometimes even in spite of an autologous stem cell transplant. In this slide, I just wanted to point out some of the progress that has been made in the field of T-cell lymphomas. So before 2009, we really didn't have anything specific that was used to treat T-cell lymphomas. And the first agents to be approved for a relapse PTCL were pralatrexate and romidepsin in 2009, and then came belinostat, chinomide was approved in China. You have mogamulizumab that got approved in Japan for CCR4 containing PTCL. Brentuximab vedotin was approved in 2017, and it was approved for upfront therapy in 2019. And since then, we are waiting for the next approval. Most likely, it will be a PI3 kinase inhibitor and an EZH2 inhibitor. However, in spite of all this, if you look at outcomes of patients with T-cell lymphoma, it hasn't changed much since 2004, 2008, and even in more recent studies where the outcomes remain poor. And so really there's a huge unmet need of trying to find more effective treatments for patients with what untreated as well as relapsed T-cell lymphomas. So what are some of the challenges in treating patients with T-cell lymphoma, both in the upfront and the relapse setting? So first of all, these are rare diseases. And the studies that are conducted are relatively small compared to other diseases. And they usually take a one-size-fits-all approach where all subtypes can be included in the study. And what we're finding out is that these are really not, this is not one disease. There are molecular, epigenetic, and differences between these different subtypes. And hence, really, I think the treatment needs to be tailored to each subtype, which is challenging given the rarity of these diseases. And it's no wonder that we see, different outcomes. In addition, what's happened is that for years, the approaches have been to just use treatments from B-cell lymphomas and try to use them for T-cell lymphomas, including non-overlapping combinations of chemotherapy or just mixing together even newer chemotherapy agents, and that hasn't worked. So what we find is that the overall survival in the relapse setting without allogeneic transplant remains less than 1 year. This slide shows a list of FDA-approved agents that have been studied in relapse PTCL and are available in the US, and also includes some off-label standard agents. So looking at their response rates, you can see that the overall response rate, for example, for HDAC inhibitors like romidepsin and belinostat is about 26 to 25%. For pralatrexate, it's 29%. CR rates are all below 20%, except for brentuximab vedotin in the ALCL setting, where the response rate and CR rate is very high, indicating that you need to really, a targeted agent is perhaps more effective. Again, median duration of response is 8.4 months for belinostat, 17 months for romidepsin, and only 10 months for pralatrexate, and 13.2 months for brentuximab. If you look at some of the off-label agents like lenalidomide or bendamustine, the response rates are higher for bendamustine, but the duration of response is really short at 3.5 months. Same is true for combination chemotherapies. You may have high response rates, but those don't last unless they can be used as a bridge to an allogeneic stem cell transplant. You all are probably aware that romidepsin was withdrawn. The indication for relapse PTCL was withdrawn in the US in 2021 after the negative phase 3 study of romidepsin was CHOP versus CHOP, though it is still available for relapse cutaneous T-cell lymphoma and for ongoing research and combinations. Some studies still ongoing with combinations of romidepsin. So I just showed you the low response rates for approved FDA agents. So really there is a lot of work that needs to be done. And so the field is now moving towards looking at novel targets and really moving away from chemotherapy. The tumor microenvironment is important, and it seems like we need to really understand the biology of these diseases and try to find treatments that are more, that target some of the dysfunctional pathways. So I'm going to mention and show you data on some of this work that's being done. So one approach is to target the PI3 kinase AKT pathway. This has been very promising. I'm going to show you data. Epigenetic therapy has always been exciting for T-cell lymphomas, and then there is new targets like the EZH2 pathway with some agents that like belinostat. There's also the hypomethylating agents like kinase acidity that have been studied and are being evaluated. As I showed you data for the upfront alliance study. Then surface targets like CD30, we already know the story of rituximab vedotin, both in the upfront setting as well as the relapse setting, but there's other ways to target CD30 like CAR T or some bispecifics. The immune and cell surface targets like PD-1 and PD-L1 axis or the CD47 or CD alpha axis is also a potential strategy. There's other surface molecules like CD5, CD70. So all of this is currently being evaluated to see if we can improve the outcomes of these diseases. So I'm going to be focusing on a few of these pathways, the PI3 kinase inhibitors, EZH2 inhibitors, the JAK-STAT pathways, and some novel surface molecules, and briefly touch upon combination therapies and CAR T cell studies. So first of all, I want to focus on the PI3 kinase pathway. So this work really came about from in vitro cell line as well as animal data. And it was found that there was high expression of PI3 kinase isoforms in all samples of T cell lymphoma, and high PI3 kinase alpha expression was linked to poor survival. And there was data to support that inhibiting the PI3 kinase alpha and delta isoforms resulted in suppression of tumor cell growth, both in vitro and in vivo. And this led to clinical trials using agents like duvelisib and tenelilisib in T cell lymphomas. Now, unlike the B cell lymphomas, these agents are actually quite promising in T cell lymphomas. I'll show you some data. And in spite of the toxicity issues, I think they remain very promising, though we are still waiting for actually with an FDA approval. But the data is very robust, as I will show you in a minute. Other PI3 kinase inhibitors have also been evaluated in T cell lymphomas. Here is the data from two others, linvoseltamab, which has been studied in China, targets PI3 kinase delta isoform with response rates that are close to 60% and CR rates of 35%, and median duration of response of about 15 months. Tenelilisib has also been studied both in PTCL and CTCL with similar responses seen as in duvelisib. Moving on to EZH2 inhibitor. Now, EZH2 pathway is involved in methylation of histones, and EZH2 is overexpressed in PTCL, which correlates with a high tumor proliferation rate. And there are some mutations that have been seen in T cell lymphomas. And on the right side, you can see the EZH2 expression in various PTCL subtypes by immunohistochemistry. The EZH2 inhibition remains a attractive target. And so again, with the last ICML meeting in Lugano, there were two abstracts that were presented looking at the use of oral EZH2 inhibitor in relapsed refractory PTCL. Again, these were early studies, but you can see the waterfall plots are pretty impressive with a lot of patients showing response and clinical benefit. Now, going back to an older agent, is a cytidine or a hypomethylating agent. There's an IV and oral formulation. And there was a study from France that looked at the use of oral azacitidine in relapsed refractory T follicular helper cell lymphoma that was impressive, showed some high response rates. These were patients who also had MDS at the same time, which led to the use of this agent in the first place. So this led to this phase 3 Oracle study of oral azacitidine versus investigator's choice. This was conducted mostly in Europe, so the investigator's choice was gemcitabine, bendamustine, and romidepsin. And what you see here is that this is actually a negative study. So the primary endpoint was progression-free survival based on local assessment. And the study would have been considered positive if one-sided stratified p-value was less than 0.25. So it didn't meet the criteria. But if you looked at overall survival, patients who got azacitidine actually had longer survival, 18.4 months versus 10.3 months as investigator's choice. So this poses an interesting question about what really is going on, and the feeling is that this is likely an effect in the tumor microenvironment. So even though the patients are not, the tumor is not responding, the patients are living longer, there's a clear benefit. So this agent is now being evaluated in combination with CHOP, and there are positive responses in T follicular helper subtype T cell lymphomas. The dysregulation of the JAK-STAT pathway is seen in many subtypes of T cell lymphomas, and hence targeting this pathway seems like a very attractive therapeutic option. This is a study that was conducted with ruxolitinib, a JAK1 inhibitor, in patients with relapsed refractory T-cell lymphomas. In this study, the patients were classified into 3 cohorts. Cohort 1 was patients who actually had the JAK-STAT mutation. Cohort 2 was patients who had upregulation of STAT3 by the IHC in the tumor samples. And cohort 3 was patients who either did not have the mutation or this could not be evaluated. And when you looked at response rates, it was definitely higher in cohort 1 and 2. And if you look at different subtypes, there were high response rates seen in TPLL and T follicular helper cell, a subtype of T-cell lymphoma, as well as TLGL. Again, this was a big surprise. The numbers are really small. On a similar theme, this is looking at golidocitinib, another JAK inhibitor for relapsed refractory T-cell lymphomas. This study was conducted mostly in China, and the response rates remain 44.3%, with a CR rate of about 23.9%. Again, if you look at different histologic subtypes, the response rates are pretty high in patients with PTCL-NOS and AITL. So golidocitinib has also been studied as a maintenance treatment after initial systemic therapy with CHOP or CHOP-like regimen. This abstract was presented at the recent Lugano meetings, where they presented data on this trial. And in this, patients in cohort 1 received treatment after achieving a CR. But cohort 2 is the interesting cohort where the patients only have a PR, but they continued to receive this agent, and this PR was converted to a CR in about 50% of cases, with a median duration of response of 23.9 months. So this is a promising strategy of maintaining patients and achieving remission after initial therapy. So before I move on to combination treatments, I wanted to talk to you a little bit about cytotoxic lymphomas and a promising new agent. So these are the rare of the rares. Some subtypes of T-cell lymphomas include things like the intestinal T-cell lymphomas, hepatocellular T-cell lymphomas, subpiniculitis like T-cell lymphoma, the gamma delta T-cell lymphomas. Overall, their outcomes poor. Their representation in T-cell lymphoma trials is either very limited or they are excluded. There is no standard or established patterns of care. The general principles are to try to give some kind of induction therapy and take them to an allogeneic transplant as possible. So there is a demand and there's a need to really find treatments that are focused on this group of lymphomas as well. These cytotoxic T-cell lymphomas are characterized by the expression of CD94 on their tumor cells, which is also expressed on normal cytotoxic and NK cells. So DR01 is a non-glycosylated human IgG antibody against CD94 that obviously binds to CD94 on these tumor cells, but also engages through its Fc gamma receptor CD16A and triggers antibody-dependent cellular cytotoxicity by effector cells or fratricide, and causes rapid depletion of the target tumor cell. So this is currently being evaluated specifically in cytotoxic T-cell lymphomas and LGL. So this is the data for cytotoxic T-cell lymphomas, and different dose levels have been evaluated in the early phases of the study. Responses were seen across all the different dose levels, even though the numbers were small, and all the different subtypes of T-cell lymphomas, or cytotoxic T-cell lymphomas. So this is currently, I think, a very promising agent for treating cytotoxic T-cell lymphomas. The study is ongoing. Response rates are around 50% at this time, especially in SPTCL. And we've had several impressive responses where patients have been taken to an allogeneic transplant. So this is going to be looked at in the upfront setting as well. So now I'm going to move on and talk a little bit about combination therapy. So far, we've been focusing on single agents, and we've seen the response rates get higher with single agent therapies, but obviously there's room. So the first combination I want to talk about is romidepsin with duvelisib. So duvelisib and romidepsin both are active in T-cell lymphomas. Duvelisib had been noted earlier had a response rate of close to 50% as a single agent. You combine them together, and this was studied, a phase 2 study, and the response rates were not that much higher, around 53% or so. But what they saw was that actually reduced the toxicity associated with duvelisib, particularly hepatotoxicity. So this combination is now mostly used really in an attempt to try to reduce the toxicity associated with duvelisib, and so that patients can continue to be on treatment. This is a epigenetic therapy. It's a combination of 5-azacitidine with romidepsin, with high response rates, even though this approach is not FDA approved, but you can see that a lot of the patients remain in remission, and had either CR or PR. Response rates were closer to 70%, particularly in angioimmunoblastic T-cell lymphomas. And this is a combination of ruxolitinib with duvelisib, so targeting the JAK-STAT pathway and the PI3 kinase pathway. This is, if you remember from the ruxolitinib study, response rates were particularly high in TPLL and T follicular helper cell lymphoma. So this combination is very promising as well. Overall response rate of the combination is 41%. CR rate is 24%, but the highest activity, close to 79%, has been observed in T follicular helper and close to 60% in TPLL. So the trial is now focusing on these two subtypes, and it's ongoing. Particularly for TPLL, it is you can enroll patients who are untreated as well, which is very promising. Since the only other treatment we have is alemtuzumab, which is pretty toxic. So this is a combination of EZH2 inhibitor with a PI3 kinase inhibitor, tazemetostat plus amdizalisib in relapsed refractory PTCL. This abstract was also presented at the recent Lugano meetings. You can see the waterfall plot here, and it is showing responses, a significant number of responses. And they also looked at the mutational landscape and tried to correlate that with some mutations. So neither EZH1 nor EZH2 mutations were correlated with response, but mutation in the TEC2 pathway, especially with the ROA, seems to predict for higher response rates. I wanted to mention a few words about CAR T therapy, T-cell lymphomas. It has been challenging and not as successful as it has been in B-cell lymphomas. Nonetheless, there are a few promising agents. There's CAR Ts directed against CD30 that have been evaluated. CAR Ts directed against TCR-BC1, which is expressed in about 35% of T cells. There are NK CARs and allo CARs that are being evaluated. One of them is directed against CD70. There's a CD5 CAR. So all these studies are ongoing, and we're hoping for some positive results. Finally, I just wanted to summarize the current recommendations for patients with relapsed PTCL. Again, this is mostly for nodal subtypes. Basically, these patients can only be cured with an allogeneic stem cell transplant. So if you know that the patient has a known donor and you want to lead a complete response, you could consider a combination chemotherapy, clinical trial, or regimens with high CR rates. If the transplant is unclear, you're still looking for a donor, again, you could consider a clinical trial or a single agent combination biologic therapy that could be continued for a while. And if this transplant is not an option, then you need to think of, again, a clinical trial or single agent combination. You could go until they can, develop intolerance or progressive disease. Hopefully go from one agent to another, but overall the outcomes remain poor unless the patient can really go to an allogeneic transplant. In the end, I want to conclude that T-cell lymphomas show marked molecular and biologic heterogeneity. New active agents are being identified that target dysfunctional pathways and can lead to improved clinical outcomes both as single agents and as combinations, and can also reduce the toxicity associated with some of these agents. In the end, we need to develop specific treatments for specific subtypes based on molecular and biologic subtyping and understand the mechanism of resistance. On the right side, I'm showing the current suggested treatment regimens for relapsed refractory T-cell lymphomas. These agents in alphabetical order, and we encourage clinical trials at all stages of diseases. Thank you very much. Finally, I've taken the liberty of putting together some ideas about what to do for these rare diseases, but resources are limited. So I think it's very important to understand disease patterns in any community. So establishing some kind of an epidemiologic database a tumor registry to collect data, maybe amongst some of the bigger centers, will be helpful to see what kind of diseases are actually walking through the door. Establishing better diagnostic tools at a minimum, look for CD30 expression, trying to see if there is any other marker that pans out and what's being seen in the community. Try to use what's available. You may not have all the novel agents and drugs, but there's a lot of drugs that are being developed in solid tumors. Lenalidomide is a great example. It's available in many places and has been in use. Thank you very much. Now I'll take some questions.
Thank you, Dr. Jasmine. We'll take the questions later on. We have one last talk. This is on update on management of myelofibrosis and role of transplant in myelofibrosis. This will be by Dr. Nida Anwar. She's an honorary consultant hematologist at NIBD and is currently working in NHS as a consultant hematologist in Blackburn Hospital. So Dr. Nida Anwar.
Dr. Isman and all the team of Shaukat for giving me this opportunity. Today I'm going to speak about updates on the management of myelofibrosis and the role of transplant. Before I start, I have nothing to disclose. Primary myelofibrosis is a myeloproliferative neoplasm that is characterized by stem cell-derived clonal myeloproliferation, often accompanied by various mutations like JAK2-CALR and MPL mutations. The additional features include bone marrow reticulin or collagen fibrosis, aberrant inflammatory cytokine expression, presence of anemia, hepatosplenomegaly, extramedullary hematopoiesis, and constitutional symptoms like cachexia. Moreover, there's a risk of leukemic progression and shortened overall survival. The current diagnosis of myeloproliferative neoplasm is based on 2022 international ICC criteria that involves a composite assessment of the clinical and laboratory features and subclassification of overt fibrotic phase to early pre-fibrotic state, which is very, very imminent, and it has to be distinguished from other MPNs, specifically essential thrombocythemia. However, rarely some non-clonal bone marrow fibrosis may accompany spectrum of some autoimmune conditions or some secondary conditions, presumably like primary autoimmune myelofibrosis, which has to be distinguished. So the careful bone marrow examination with typical findings like megakaryocytic clustering and atypia, along with cytogenetic and mutational profile, in turns provide integrated diagnostic information. It is very, very important for the diagnosis. So there is a morphological distinction between the overt versus early pre-fibrotic phases that has to be carefully assessed. As per the criteria, the overt primary myelofibrosis is characterized by megakaryocytic atypia and the clustering, ballooning, bulbing of the megakaryocytes, along with the collagen and reticulin fibrosis. However, the pre-fibrotic phase could be characterized by loose clustering of the megakaryocytes, less degree of the collagen and fibrosis. And however, the ET is characterized by typical staghorn appearance of the megakaryocytes, staghorn appearance, and this all has to be distinguished carefully before you make a morphological diagnosis. When polycythemia vera is suspected, the criteria includes hemoglobin in men more than 16.5 and women more than 16 grams per liter, and JAK mutation V617 exon 12. So if this is positive, the most likely diagnosis is JAK2 positive polycythemia vera, which has to be distinguished from the primary myelofibrosis. However, if it's negative, the diagnosis is unlikely. When we talk about the ET, usually the platelet counts are persistently more than 450, so that is characterized by mutational screening of either JAK2, V617F, CALR, or MPL. If this is positive, ET is most likely, depending upon the morphological findings of megakaryocytes. However, if it's negative, it is still possibility keeping with the triple negative primary myelofibrosis. And when primary myelofibrosis is suspected, it's characterized by the major criteria, along with minor criteria, including anemia, splenomegaly, leukoerythroblastosis, and bone marrow biopsy with mutational screening and cytogenetics. Presence of JAK2 in 60%, CALR 22%, MPO 8%, and sometimes there could be triple negative in 10% of the cases. So careful morphological assessment along with the clinical criteria is very important to distinguish between the overt fibrotic primary myelofibrosis, ET, and polycythemia vera. The risk stratification includes the various risk stratification models, including IPSS, DIPSS plus, MIPS, and GIPS. So the contemporary prognostic systems, including the current GIPS, which is genetically inspired prognostic scoring, and MIPS 70 plus. The GIPS is basically exclusive on the mutations and karyotype. However, the MIPS include in additional clinical risk factors as well. So as we've discussed, the international prognostic system involves various variables, including age, constitutional symptoms, hemoglobin, leukocyte count, circulating blood cells, and categorizes into very low, low, intermediate, one, intermediate, high, and very high. The dynamic international prognostic system could be applied anytime from diagnosis to later on in the diagnosis, and includes various variables like age, constitutional symptoms, hemoglobin, leukocytes, circulating blood cells, and the DIPS plus additionally includes the unfavorable karyotype, the platelet count, transfusion requirements, and in turn categorizes the risk into very low, low, intermediate, one, intermediate, two, high, and very high. In terms of the MIPS 70 is mutational enhanced international prognostic system, which is applied to age more than equal to less than 70 years, and includes equal to more than 2 high-risk mutations, leukocyte count, platelet, hemoglobin, circulating blood cells, the degree of bone marrow fibrosis, along with the constitutional symptoms. The presence of CALR mutation absence carries a prognostic point, along with 1 high-risk mutation. However, the genetically inspired international prognostic system is just CHIPS, which in turn include very high karyotype, abnormalities, unfavorable karyotypes, along with specific mutations like ASXL1, SRSF2, U281, Q157 mutation, and typical absence of CALR, which includes one additional point. So it in turn again categorizes the patients into very low, low, intermediate, 1, intermediate, 2, high, and very high. When it comes to the management, the only treatment modality that is currently capable of prolonging the survival and potential cure in primary myelofibrosis, allogeneic stem cell transplant. However, it is associated with at least 30% rate of transplant-related deaths, that is, transplant-related mortality and severe morbidity, specifically the graft rejection and graft versus host disease, regardless of intensity of the conditioning used. However, a very careful individual patient assessment and careful risk assessment of the risk of transplant must be weighted against expected survival, what if transplant is not done. So there has to be very careful patient selection in which individualized approach. However, the current drug treatment modalities in primary myelofibrosis are mostly palliative, and they do not modify the natural history of the disease, nor they prolong the overall survival. So the basic algorithm for the primary myelofibrosis treatment in general, clinical trial option should be offered to all patients at every stage. And all patients should have a baseline dynamic MPN burden assessment done on the baseline, along with careful documentation of the spleen size and validated prognostic scoring system performed. All the patients should be discussed in multidisciplinary team meeting, and early identification of the patients eligible for the transplant and early referral to transplanting is imminent, and all patients should be offered clinical trials if available. The monitoring of the symptoms, spleen response at point of treatment goal is very important, along with the early warning of the disease progression. So if in case of low risk and intermediate risk, if the patient is asymptomatic, just observe and enroll the patient in the clinical trial where applicable. However, if the patient is having symptomatic or bulky splenomegaly in case of low or intermediate risk, the treatment potential options that we have are JAK2 inhibitors, dilated interferons, hydroxycarbamide, if the proliferative counts are there, and the option of the clinical trial. However, in case of intermediate to high and very high disease, it has to be carefully assessed eligibility for the transplant. If the patient is transplant eligible, offer the patients with JAK inhibitors to minimize the spleen and symptom response, and then proceed for the allogeneic stem cell transplant as soon as possible, ideally at the time of the batch response. However, if the patient is not eligible for the transplant, the treatment modality is to offer the first-line JAK inhibitors to maximize the spleen and symptom response. If there's a response, continue with the JAK inhibitors. However, if there's no response or the less response, offer the patient second-line JAK inhibitors or other novel agents for the best supportive care. When it comes to the management of anemia and primary myelofibrosis, this is very, very important to document the baseline serum erythropoietin levels. Also document the exclusion of various hematologic deficiency, ongoing bleeding or hemolysis, which could be contributory to the anemia. If the serum erythropoietin level is adequate, which is considered around 500, proceed the patient with danazol and assess the response at 6 months. If there's a response, continue with the danazol. However, if there's no response, then consider alternatives like momelotinib, immunomodulated drugs, luspatercept and combination. However, always consider momelotinib in all patients because it targets anemia, splenomegaly, and symptoms that could be irrespective of the epokine levels. However, if at the baseline there's inadequate erythropoietin levels, just give the erythropoietin stimulating agents, assess the response at 3 months. If there's a response, continue with it. If there's no response, we can try the option of danazol. Coming to the management of patients of myelofibrosis with thrombocytopenia, which require the treatment, it's important to assess the platelet count on the baseline. If the platelet count is between 50 to 100, the first line treatment is ruxolitinib, starting with the low dose and carefully titrating the dose depending upon the platelet count. These are the approved first line available treatment in the United Kingdom. However, the other options include the pacritinib or momelotinib. However, they are not currently routinely available in the UK, and indication could be suggested depending upon potential circumstances. In the second line, the options include pacritinib and momelotinib. Again, momelotinib is not currently available in routine in the United Kingdom. Coming to the patients who present with thrombocytopenia, platelet counts of less than 50, the first line option includes starting with the danazol doses 200 and titrating gradually depending upon the response and platelet count up to 600 milligrams daily. The low dose ruxolitinib, depending upon the counts and titrating with close monitoring of the blood counts, is another option which could be tried in the first line. The other options of pacritinib is again not routinely available in the United Kingdom and can be suggested depending upon potential placing. The second line options in all the cases are momelotinib, starting with 200 milligrams if licensed in the second line. In all of the patients, the considerations at all line include again enrollment in the clinical trial whenever available, and if the patient falls into the transplant eligible group, the patient should be referred to the allogeneic transplant center as soon as possible. At any points of time, depending upon the platelet count and the bleeding, platelet transfusion may be required in patients in case of bleeding and surgery. This is another algorithm copied from American Journal of Hematology by Jeffrey and colleagues. Again, it's a summary depending upon very high risk, intermediate, low, and very low risk. To summarize again, more or less management is the same. In case of asymptomatic patients of very low and low risk, observation only. In case of symptomatic patients, again, the preferred option is an investigation treatment, and otherwise, depending upon the symptomatology and the symptomatic splenomegaly, the options include JAK inhibitors like ruxolitinib. If the ruxolitinib fails, there has to be a reason for the change. For the option of anemia, in case of anemia, the option is momelotinib. In case of thrombocytopenia, the option of pacritinib. And in case of symptomatic splenomegaly, you can try the pacritinib as well. In case of symptomatic low-risk patient, the preferred option is investigational treatment, enrollment in the clinical trial, and again, the JAK inhibitors were applicable. In case of intermediate risk, there has to be an individualized approach where the patient is transplant eligible or non-transplant eligible, along with the symptomatology. If the patient is having anemia, splenomegaly, or symptomatology, one of the options is momelotinib that act on the anemia as well. Assessment of transplant eligibility is imminent in case of high and very high risk patients. So if the patient is transplant eligible, proceed for the allogeneic stem cell transplant as soon as possible after documented response by the JAK inhibitors. And if the patient is transplant ineligible, proceed for the investigational treatment or specifically the symptom-directed treatment. So if the patient is having anemia without any symptomatic splenomegaly, the various options include androgens, DAN, and SOL, thalidomide, lenalidomide, avoiding stimulating agents, and the second line again with the option of momelotinib and pacritinib, possibly commencing with the lower doses. In case of symptomatic splenomegaly with cytosis without anemia or proliferative neoplasm, the options include hydroxyurea, and if hydroxyurea is not applicable, the option is ruxolitinib. As we've discussed, the risk adapted treatment. So in case of very low and low risk, observation alone is sufficient. Allogeneic stem cell transplant for very high and high risk diseases, and drug therapy, as we've discussed, which targets anemia, splenomegaly, and constitutional symptoms. So to summarize, the symptom-directed treatment, the management of anemia in case of absence of symptomatic splenomegaly, non-JAKi drugs, including danazol, androgens, erythropoietin stimulating agents, anemia associated with symptomatic splenomegaly, JAK inhibitors, and coming to the symptom-directed treatment in case of JAK inhibitors, JAK inhibitors in general have not been shown to reverse the bone marrow fibrosis per se. They do not induce complete or partial remissions. Instead, they are limited to symptom relief aspect and reduce the spleen size. However, the recently introduced JAK inhibitors, including momelotinib and pacritinib, might pose erythropoiesis benefit. The ruxolitinib was the first JAK1 inhibitor which was licensed upon the pivotal evidence from the COMFORT 1 and COMFORT 2 studies. It compared basically the ruxolitinib with the placebo and the best available therapy, and it documented that earlier initiation of ruxolitinib may improve the clinical outcomes with fewer cytopenic events, more durable spleen volume reduction, and in turn the prolonged overall survival. In general, around 80% of the patients on ruxolitinib experience equal to more than 10% reduction in the spleen volume, and it elicits rapid symptomatic responses in 40 to 50% of the patients, achieving 50% reduction in symptom burden on an average around 8 weeks when treated with adequate doses. However, it can be discontinued if there's no response or no improvement in symptoms or spleen size after 6 months of treatment, despite dose optimization. So the JAK inhibitor choices in case of ruxolitinib failure or in case of thrombocytopenia. So the ruxolitinib intolerance are more likely to respond as an alternative JAK inhibitor as opposed to the patients who are ruxolitinib resistant. As we've discussed, momelotinib in case of anemia and pacritinib for thrombocytopenic patients, specifically when the platelet count is less than 50. So coming to the transplant, it remains the only curative option for the suitable candidates with primary myelofibrosis. And again, careful patient selection and careful patient clinician information discussion at the baseline is mandatory. The optimal timing of the transplant is individualized for each patient and depends upon the estimated rate of disease progression, the recipient health and the performance status in general, the treatment responses or any previous treatment if given, the availability of the potential donor, the financial and psychosocial factors. The European bone marrow transplant group basically suggests that all patients with intermediate to or high-risk disease according to IPSS DIPS or DIPS plus age equal to or less than 70 years should be considered potential candidates for the transplant. Also, patients who are less than 65 years of age with intermediate 1 disease should be considered potential candidates for the transplant if they present with either refractory transfusion-dependent anemia, or if their peripheral blood loss more than 2%, or if they present with adverse cytogenetics. ELN and EBMT combined guidelines suggest that patients in intermediate 1 risk group who are triple negative or who are positive for the ASXL mutation or both should also be considered for the transplant. Coming to the transplant, the pre-transplant pain management is also imminent because it impacts the post-transplant outcomes. Symptomatic splenomegaly or massive splenomegaly is associated with high risk of graft failure, poor graft function, and adverse non-transplant related mortality and overall survival rates. So the options include splenectomy, use of JAK inhibitor therapy, and involve radiotherapy. So the pre-transplant therapy with available JAK inhibitor enrollment in the clinical trials is imminent to maximize the spleen responses, and it is warranted prior to the transplant, especially in those patients with bulky splenomegaly. One of the large EBMT retrospective studies suggested that splenomegaly should ideally be reduced to less than 5 centimeters palpable prior to the transplant, as it is associated with improved engraftment success. In addition to the specific pre-transplant workup, including the standard organ function assessment, given the risk of portal hypertension associated with bulky splenomegaly, OGD should be performed to rule out the occult varices presence. Moreover, the liver imaging and transient elastography, particularly in those with liver function abnormal tests, should also be done. Iron overload is another aspect that is associated with graft rejection and poor transplant outcomes. So transfusion overload can negatively impact the marrow microenvironment. So our aggressive iron chelation, especially with deferous rocks, may be used prior to the transplant in suitable individuals to reduce potential risk of engraftment failure. Coming to the donor choice, matched sibling donors, allotransplant with fludarabine and melphalan is associated with higher engraftment rates, reduced non-transplant related mortalities, and improved overall survival. The International Bone Marrow Transplant Research retrospective analysis in reduced intensity conditioning suggested that 5 years overall survival using a matched sibling donors compared to those with unmatched or unrelated donor was 56% as compared to 34% respectively. A recent study evaluating the haploidentical transplant utilizing the post-transplant cyclophosphamide PTCI demonstrated 3-year overall survival rate and relapse-free survival of 72%, 42% as 72% as compared to 42% respectively. Usually, the stem cell dose in primary myelofibrosis is peripheral blood rather than the bone marrow. However, the large comparative studies are lacking still evidence. However, one of the recent EBMT study demonstrated that CD34 stem cell dose of more than 7 in matched sibling donors is associated with improved overall survival and platelet engraftment. When coming to the conditioning choice, the older patients or those with significant comorbidity, a reduced intensity conditioning is appropriate, whereas for fit, comparatively younger patients, TBI-based myeloablative conditioning regime should be used, as the data suggests improved graft versus post-disease free survival and relapse-free survival. A variety of the regimes have demonstrated acceptable transplant outcomes, most commonly fludarabine or busulfan or melphalan-based regimes in the United Kingdom. The post-allotransplant monitoring and management of the poor graft function and management of relapse. So the presence of MRD persistent both at 3 and 6 months and thereafter post-transplants are associated with high risk of the clinical relapse. Coming to the new investigational drugs in the clinical trials include P13IK inhibitors, including barcitinib, histidine demethylase inhibitors, including LSD1, telomerase inhibitors, including amtilstat, pegylated interferon alpha, luspatercept, also the BCL2 and BSXL1 inhibitors, including navitoclax. In the end, I thank you all for your patience, and I'm happy to take any questions if any.
Thank you very much, Dr. Nagia. That was very elaborative, very well explained. Now we open the panel for discussion. We'll make sure if we have Dr. Jasmine Zain online with us. So I think I'll start a question. For Professor Jasmine. Dr. Jasmine, can you hear us?
Yes, I can. Can you hear me?
Okay. Yes, we can.
Let me try to
So I
see
have
if I
two-
can, you can see me. Now you can see me
Yes,
too.
we can see you as well.
Okay,
I have two small questions.
sure.
Number one, for offering auto transplant to the T cell lymphomas,
Yes.
is it regardless of any subtype that you're offering, or are there certain subtypes you prefer offering them to? And
Yes,
number
so, sorry, go ahead.
And the number two, with all these agents, azacitidine and EZH2 inhibitors and ruxolitinib in relapsed
Sure.
refractory settings, if in a country like us where we cannot
Sure.
offer autotransplant to all T cells, is there any role of these agents upfront with the chemo or as maintenance?
Right, so that's a great question. So for your first question, the auto transplant we offer, the recommendation is to offer only in nodal subtypes in first remission. So that's PTCL-NOS, anaplastic large cell lymphoma, ALK negative. Usually ALK positives do well anyways, unless it's high IPI, and angiomoblastic or T follicular helper cell. We usually don't offer it to the other subtypes. They tend to not be very chemosensitive anyways, hepatosplenics, the gamma deltas, certainly not for cutaneous T cell lymphomas. So it really is limited to the nodal subtypes that tend to be more common anyways. So I hope that answers your question. The
Yes.
second part, yes. So the transplant question is, as you know, still somewhat debatable in the sense we don't have randomized studies to really say that that's the best approach. It is one approach. It does improve progression-free and overall survival, but we do have a lot of relapses even after auto transplant. So having said that, there is efforts to incorporate these targeted agents, both in combination with CHOP. I mentioned the Alliance trial, so that's ongoing. We'll see when that reads out, if that really made a difference. There are some smaller studies, combination of 5-azacitidine with CHOP. There's some of these agents as well. But they're not randomized, so they're not standard of care yet. But certainly there is push to try to see if we can improve the outcomes of CHOP and not have to do transplants in these patients. Secondly, there's also sort of a lot of trials ongoing of maintenance of these agents. So if either post auto transplant or even without transplant, I sometimes put patients on duvelisib maintenance after their initial therapy if they're not transplant options or if the remission is not great. Certainly romidepsin I've used quite a bit as maintenance. So there's not a lot of randomized trials to support this, but certainly there is it makes sense, biologic sense to try to do that. And yes, a lot of people are doing that. So that's something that can absolutely be tried. And, if you have patients and you want to do a small study, that would be an option. Yeah.
Thank you very much.
Thank you very much, Professor Yasmin. My question was the same. You have already covered. For the patient, anaplastic large T-cell lymphoma, ALK negative, we have transplanted after brentuximab and GOP. Is there any recommendation of brentuximab maintenance? Because I searched the literature, it was a serving officer. There was no literature about the maintenance with brentuximab. So can you guide about that?
Sure, absolutely. So there is a phase 2 study from MD Anderson from many years ago by Michelle Finale, where she actually did a small study of patients who got BV chip followed by a BV maintenance. It did not include transplants, and I think the follow-up was about 5 to 6 years with a very flat curve of progression-free survival. So that's what actually led to the Echelon-2 study, where they randomized it against CHOP. But in Echelon-2, they did not study the transplant question. When I was at City of Hope, we did do a study of CHOEP plus BV that you were just talking about, followed by maintenance, followed by autologous transplant. Either patients went to transplant or did not go to transplant, but everybody got BV maintenance. And the best outcomes are with patients who had the BV chip transplant and then BV maintenance for up to a year. So if they could tolerate it. Obviously, if they developed neuropathy, we stopped earlier. And that study actually included a lot of non-ALCL patients as well. It's published by Herrera et al. And we have now expanded it and it's also open at MSK. So
we're trying to get a bigger cohort of patients. But yes, there is some data to suggest that BV maintenance after auto transplant, even with ALK negative ALCLs, is probably useful. Okay.
Questions?
To answer your question.
Hi, assalamu alaikum, everyone. I have a question for Dr. Marine right here and anybody who treats acute myeloid leukemia. I think, as you said, azacitidine venetoclax has really changed the way we treat AML. At least in Pakistan, we have a very, very high induction mortality. I mean, whatever we do, we are about 20 to 30%. And what we have been seeing is a trend, at least in the community, at least at larger centers where I am and maybe where you are, we still are using 7+3 because that's where the data is. But in the community where AML is being treated, people have been, because of that induction mortality, they've been using aza-ven as for induction. And so now when you do that, and you're not getting, and we don't do MRD, so you're like stacking yourselves against analysis which is inappropriate. So when somebody, a young patient in the community, has come to you with treatment with aza-ven and is in morphological remission, so what is your take on that? I'll tell you what my take on it is, because you're not getting that deep MRD, your morphological remission, if it's an intermediate risk patient, take them to a transplant, right? But these are the 2 points that I want to talk to you about. What should we be advocating 7+3 and talk to our communities about referrals, or should we be making a plan or a guideline of what to do after aza-ven?
Thank you very much, Munira, for a very, very pertinent question for the real world. That is what we all come across in our clinics. Yes, the community is moving towards aza-ven due to lesser side effects, due to daycare basis. They come to the daycare, have aza and go back. And oral aza is also available, by the way, a bit expensive, but it is available. So if a young patient comes to me with aza-ven, not in morphological remission, I would definitely like the patient to be in morphological and MRD negative before taking the patient to transplant. So MRD is essentially should be negative before taking the patient for transplant for AML. Otherwise, even after transplant, they relapse so early. So most of the times, now I say that ALL is a bit better in a transplant, especially the Philadelphia positive ALL, because we have something to give. That's why we were talking about venetoclax maintenance. So even if you take the patient with MRD negative to transplant, they are at a high risk of relapse. Yeah, but for transplant, MRD is essential, either a molecular MRD if a marker is present, or the MRD by flow MRD, or at least morphologically leukemia-free state, that is MLFS. These are essential for treatment.
Are you doing MRD in AML patients?
Yes, we do. If
By
some
PCR?
marker, if there is some marker on flow, we do the MRD on flow. If there is some marker on PCR, we do the MRD by PCR. If there is no marker and the patient has already been treated, then we rely upon MLFS, morphologically leukemia-free state.
Okay, and what
And we
about?
are not taking the patient to transplant without permission.
Yeah.
That is the biggest issue. So in ALL, checking MRD is a very, very well established process.
True.
AML is extremely complicated and it is very patient specific and all of it. So currently, agar koi molecular marker hai, agar FLT3 positive aa gaya, and you can check your NGS, and if you can repeatedly check the NGS on a patient, that helps. But if you don't have that, which is half of your population, right? So in that, you have to rely on flow, and flow capacity, AKU at least doesn't have it.
Munira, hum jo kar rahe na, we are doing the aberrant markers. For example, I recently transplanted a patient of AML with auto transplant. She came to us in pregnancy, fifth pregnancy. She was told everything about, the literature says that the pregnancy should continue with D3S7. But in our practice, all the pregnant ladies who were started on DA came back with abortions during D3S7, sepsis, and passed away. So we discussed all the options. She was ready to get the medical termination. D3S7 in remission, 4 IDAC in remission. She relapsed after four years. So now what did we have? We repeated D3S7. She again achieved remission. She had an aberrant marker CD7 over the myeloid blasts, which was not there after getting remission. We tested all the siblings, all were haplomatched, and they had high DSA, donor-specific antibody. We could not take that patient to allotransplant, and the least possible thing which we could do for her was autotransplant. Before autotransplant, we checked MRD with CD7 negative CD34 cells. It was negative, and we took her for transplant, and now she's 2 months post-autotransplant.
Sorry, that's great. So in our center at SKM, if we have a molecular marker, we will monitor that. But in AML, although the outcomes of allogeneic transplant, if you are MRD negative just before the transplant are better, but still that is not the target. So in AML, you need to have remission. Whether they still have MRD positivity or not, I would not delay taking them to a transplant. So it's different from ALL setting where the dynamics are different. If they are MRD positive in ALL, they will relapse because before the GVL effect sets in. But in AML, if you take them to allogeneic transplant with MRD positivity but in remission, there's still a really very good long-term survival. We've seen that in randomized trials that MRD positivity should not take you away from allogeneic transplant AML.
Yeah, I guess like I think one of the questions and one of the confusions I always have in my mind is, I think, and I'm going back to the azacitidine venetoclax question, is are we using it judiciously? Are we using it for the right patient? And it kind of still like shocks me when a young patient has gotten azacitidine venetoclax for induction when there was no contraindication to do 7+3. And that is the point that I'm trying to make, that because a lot of people in the community where they don't have a tertiary care facility, they shy away from treatment-related complications. So they're using a regimen which really has not been tested at that point. Yeah.
Thank you very much. I agree with Dr. Bakas. I was answering to Dr. Munira's question of morphological blast being taken to transplant. So we do take MRD positive to transplant, but not to autotransplant, because in autotransplant, the same stem cells would be transfused to the patient. So there is no point in doing autotransplant with MRD positivity. However, if there are morphological blast, we won't take the patient to transplant. We have tested many MDS patients with 6 to 7% blast. Literature says with IB1, you can go directly to transplant without hypomethylating agent and venetoclax and without bringing the blast less than 5%. But in all those cases, and I remember one AML-M6, IB1, IB2, they relapsed very early. So it was not cost-effective taking them to transplant without bringing them into at least morphological remission. Thank you.
So just that point that Munira made about when AZA being used judiciously or not. So I think currently at this point in time, we should discourage blanket usage of when AZA in AML patients. So obviously if they have got contraindications, they're older, then that's fine. But younger patients should still have something like DA or similar. But to improve their MRD negativity, there is data that adding venetoclax to that induction regimen, whether it's FLAG-IDA or whether it's DA, you add venetoclax, and we've seen in our center as well, patients having very deep remissions. So I think adding venetoclax to our standard intensive regime deepens your remission status.
Very much. Yeah. Okay. I can add a little bit to that, but when we're short of time, so I'll ask Dr. Nida Anwar a question as well. And regarding your take on use of azacitidine and venetoclax in the community, yes, I think venetoclax is a drug that is a pan is covering all the malignancies, and out in the community, they're using it for every other hematological malignancies. Now, these are the same patients who are not the ones who will afford induction or the ones who are going to come for the transplant anyways. So getting those to the transplant, how would you channel that's the group who's already not ready for a proper induction for the transplant? I think that's a big challenge to get them from the community to the transplant.
Can you hear me? बहुत दफा ये होता है कि they looking at I mean all cities have referral centers. We don't necessarily need to take over the patient, but we can help guide, or we can help have the resources. So I think we should not really be working in silos. And I think that's what's happening, because what I'm seeing is a lot of opinions coming for transplantation of patients, young patients being treated with 7+3 in the community. And that's why I bring this up, because we are seeing this disturbing pattern start to come up, because people are afraid of the induction mortality.
One
Very
question for Dr.
Marina. I
Nida.
would just say
Yeah.
that if somebody has given azavan without any indication to younger patient, at least assess after 2 cycles and refer the patient to a larger center for getting D3S7. So sometimes we have seen the patients being referred from different parts of the country, continuing with azavan, draining money, having blast, circulating blast. So that is a bit too much. Thank you.
Dr. Nida, one question for you. Regarding these new JAK2 inhibitors, as you mentioned that myelofibrosis is in an older age group with the age limit of 60 for the intermediate risk and 70 for high risk. We won't be seeing that here in our country, this age group going for transplant. With these new JAK inhibitors, do you think that they will somehow reduce the need for the transplant?
Thank you very much, Dr. Bushra. As compared to the other part of the world, that is Pakistan, in UK, yes, majority of the patients who come to our clinics are mostly like 50s, 60s, 70s patients. So adding these new JAK inhibitors, specifically these momelotinib in case of anemia, I won't say they decrease the need for the transplant. Of course, they don't decrease the need for the transplant, but in terms of anemia and symptomatic quality of life, they do better. But obviously, the transplant is the standard, treatment for having the, curative potential. So won't decrease the need for the transplant, but yes, a bridge to improve the quality of life, and it helps in anemia.
A quick question for Nida. So you mentioned very rightly that spleen should be less than 5 centimeters before taking the myelofibrosis patient to transplant. What do you prefer between these 3 options? So many of the studies mention JAK2 inhibitors continuation during conditioning chemotherapy. Then there can be splenectomy, and then there can be radiotherapy to the spleen. So all 3 options are there. Unfortunately, we have transplanted very few patients of myelofibrosis. So what's your take upon these 3 options? Which one would you select? Thank you.
Practically, what I've seen is the radiotherapy is least preferred option, even in the UK. And the option of splenectomy, we practically don't see that. It's very, very rare option. So practically the most applicable option, even in the Western part of the world that I see as well, is JAK inhibitors. They do really well. And practically this is the approach in Western world as well. Yeah.
Sorry, I've got a question for Dr. Yasmin.
Yeah, and this is going to be the last question.
Yeah. That's right. So, Dr. Yasmin, you mentioned earlier on that in the nodal types of T-cell lymphomas, the preferred choice or the best choice would be brentuximab followed by an autologous transplant, particularly ALK-negative ALCL or PTCL upfront,
Sure.
plus minus maintenance. Obviously, in our part of the world, if we add brentuximab to the treatment, on top of CHOP or something, that increases the cost by 10 times. So
Yes.
we quite often get this question asked that, if I use brentuximab upfront, then do I really need a transplant? Or would you rather go for CHOP or CHOEP upfront and do an autologous transplant? It's a difficult question. So
Yeah.
we have to pick, either we give BV chip on its own without transplant,
Okay.
or CHOEP followed by an autologous transplant, because it works out similar when we look at the
Right.
cost. Yeah.
Okay, tough question, tough situation to be in, sorry. So that's a great question. So if you look at the data from Echelon-2 and do a sub-analysis, it seems like the subtypes, the responses were different in different subs. So the best outcomes were with anaplastic large cell lymphoma. So I think if you have a patient with anaplastic large cell lymphoma ALK negative, I would definitely choose BV chip up front and save the transplant for later maybe, okay? If the patient has another subtype, maybe angiomoblastic T-cell lymphoma, and actually in Echelon-2, AITL, CHOP was the winner. There was, if you look at the sub-analysis, it shows that a CHOP actually had a 48% long-term progression-free survival versus BV chip. So if you have somebody with less CD, I don't know if you can do CD30 expression percentage, with the percentages low on the tumor, in anaplastic large cell lymphoma, it's high, it's over 75 to 80%. But in other, if it's low, I would probably not use the BV. I'd rather do CHOEP followed by auto transplant if you have limited resources. We add BV in those patients because we can, but again, the data is not very supportive of that. So short answer, if it's anaplastic large cell lymphoma, I would choose BV up front. And if it's AITL or PTCL with low CD30 expression, I would probably do the other option, CHOEP followed by an auto transplant. So that's what
Thanks a lot. I think we're going to conclude our session now. So it was interesting talks and excellent Q&A session as well. Thanks a lot, Dr. Nida. Thanks a lot, Professor Jesmanson. And thank you, Dr. Tanya and Dr. Marine as well. Thanks.
Thank you. It was wonderful. Thank you for letting us be part of this.
Thank you very much.
Okay. Our next session is going to be starting. So it is starting around 11:20. So 5 minutes quick break, and then we'll reconvene again.